question answer mode so that everyone is able to participate. The rules of the game are everyone will be on the mute mode. The panelists can unmute themselves. The session will be recorded and put on the YouTube channel. Your queries are invited in the chat box. You please type in your queries. We might not be able to invite you to speak because we are expecting a huge number of audience. So next slide, please. I'm handing over the session to Professor Tufan Pati sir. Sir is the chairman of this program. He has been a guiding light for us all through. Sir, over to you, and apologies for not reading your CV.
No apologies, because we must save time. Dr. Alim, thank you very much. Next slide, please. Before the slides roll on, I am introducing Dr. Alim Siddiqui and Dr. Amrit Patidossi, both professor of psychiatry in respective medical colleges and vibrant moderators of this program. Welcome, Alim, and welcome, Amrit.
Thank you, sir.
Next slide, please. Yes, sir. Dr. Mohan Isaac, a very good senior colleagues of mine whom I respect a lot from the outset of my youth, and he is now in Perth. He has kindly agreed to be the chairperson. He is clinical professor of psychiatry in University of Western Australia, Perth, consultant psychiatrist, Fremantle Hospital, Fremantle, Australia. He had been the professor and head of the Department of Psychiatry in MANS, Professional Staff Division of Mental Health, WHO Geneva, and President of Medical Pastoral Association, Bangalore. With regards, welcome, Dr. Isaac. And next, Professor Pratima Murthy. Next slide, please. The chairperson of this program, on 43rd episode, had Dr. Norman Sartorius is participating. She is Professor Pratima Murthy is the Director of National Institute of Mental Health and Neurosciences, Bangalore. She is the Senior Professor of Psychiatry and has extensive experience as clinician, trainer, and researcher, working primarily in the area of substance use disorders and improving services of persons with mental illness. She has been actively involved in training young psychiatrists in the East Asia region. She has also been involved in several digital training initiatives. Pop-ups are blocking the CV. And with this, I hand over the further meetings to Professor Mohan Isaac and Professor Pratima Murthy. Please take over and carry on. Everyone is eager to listen to Dr. Norman Sartorius and inputs from Dr. Pratima Murthy and Dr. Mohan Isaac. Please take over.
Thank you very much, Dr. Tufan Pati. I agree with you that this is a very important webinar. This is the 143rd. That, of course, is very creditable to organizers of the Thursday Music. That for the last 143 weeks, without missing even on a single Thursday, except perhaps for Christmas and New Year, you have been holding this program, and you have a wide audience. Every time I have attended, there have been 400, 450 people attending. And of course, this is recorded and a lot of people watch it later on. So credit to you all. But this program is particularly significant because we have an internationally recognized speaker. And as the organizers have said, this is especially in connection with the World Schizophrenia Day, which was observed yesterday. I am sure most of you know that on May 24th is observed all over the world as a World Schizophrenia Day. And the organizers chose to invite Dr. Sartorius for this program. And with brief deliberations with the organizing team, it was decided that, this time would be most usefully spent by asking questions and answering so that it becomes an interactive session. Alim, on behalf of the organizers, had written to the membership of the Indian Psychiatric Society, particularly its Google group members, and lots of questions have come. Large number of people have asked various kinds of questions. Of course, we learned a little while ago, Dr. Sartorius had not had a chance to see the questions, but knowing Sartorius as I do, it doesn't matter at all because he gives the best answers when the questions are put to him straight away. Now the slide has come already for introducing Dr. Sartorius. And may I request Dr. Pratima, since she said that she will not be there throughout with us. And also because in the past 2 months, I have introduced Dr. Sartorius to 2 different groups of Indian audience. First, during the ANSIPS in Bhubaneswar, where Dr. Sartorius was a speaker, where he physically came and gave a lecture. And more recently, last month, in the WPA regional conference in Calcutta, where again he physically came and made a presentation. I introduced Dr. Sartorius to the Indian audience there. So may I request Dr. Pratima Murthy, my co-chair, now to introduce Dr. Sartorius. You can either use the slide which is already presented, or you can do it the way you like to do it. Pratima, to you.
Thank you very much, sir. It's wonderful to see all of you today, this evening, to listen to the legend of psychiatry, Professor Norman Sartorius, and particularly on the occasion of World Schizophrenia Day. Let me first have the pleasure of introducing Professor Sartorius. Formally, he was the director of the Mental Health Division of the World Health Organization and served as the president of the World Psychiatric Association, and continues to mentor several further presidents of the World Psychiatric Association, still takes a very, very active role in deciding the scientific content of successive World Psychiatric Association conferences, also the European Psychiatric Association. He's the president of the Association for the Improvement of Mental Health Programs, which is an NGO located in Geneva, and he's of course had several professorial positions. Dr. Sartorius is very, very well published, has authored so many books, more than 100 books, as well as peer-reviewed journals. And his areas of interest primarily are comorbidity, stigma, human rights, physical and mental disorders occurring together, particularly diabetes, how to reduce stigma, but most importantly, his passion lies with education of psychiatrists and stakeholders in mental illness. And he's had several collaborative projects in schizophrenia, as well as other major mental disorders. And as I mentioned, particularly in the co-occurrence of mental and physical disorders. I was talking about his passion for training young psychiatrists, and Dr. Sartorius has actually mentored and trained thousands of psychiatrists all over the world, particularly for India. He's been a wonderful friend because he comes down practically every year to NIMHANS and has been training young psychiatrists. For me, it's a special pleasure to be chairing this panel because I've been one of the first students of Dr. Sartorius's training of young psychiatrists many, many years ago. And of course, Professor Mohan Isaac is also my teacher, and therefore it's a double privilege. And today, on the occasion of World Schizophrenia Day, I think we need to hear from Dr. Sartorius what schizophrenia actually means in terms of the disease, in terms of the interventions to the disease. We all know that various kinds of developments have occurred, but stigma is something that's universal. I know from personal experience that treating patients is far more than just the medication, dealing not just with stigma, dealing with so many other needs that persons with schizophrenia have, and of course, supporting their families. I've also personally experienced that where there have been caring and nurturing families, patients who have been having schizophrenia have done far better than patients without that. So I'm sure it's going to be a very exciting program ahead for us. So would you like me to start off with the first question? So in no particular order, Dr. Sartorius, a question from Dr. Sudeep Som, Kolkata reads, what is the next real breakthrough in psychiatry you're visualizing and when? Dr. Sartorius, over to you.
Sir, you have to unmute, please.
Thank you. Well, I think that the next breakthrough is that we shall have to somehow make people understand that the treatment of mental disorder is not a matter which is for psychiatrists alone. Psychiatrists play one, but not a particularly important role in the outcome and in the course of the disease. They can provide treatment, but the treatment which they provide is in fact, so to say, a chemical intervention while so many other things are of great importance. And I think that we shall have to gradually understand or make people understand what it is that needs to be done to make people with mental illness fare better in life. And I think that that is the breakthrough which will be necessary, because it means or it requires a change of the attitude, not only of psychiatrists, but also of medical doctors and of the community as a whole.
Dr. Mohan Isaac, would you like to take the next question, sir?
What I have done is, actually there are lots of questions. Some of them are similar questions. So I've grouped them. Some questions are about diagnosis and classification of schizophrenia. Some are about stigma and stigma reduction. Some questions are about the treatment of schizophrenia. Again, in no particular order, stigma was the issue discussed widely as hindrance in mental health seeking 2 decades back. It is still a major concern. Why is it so? Have we missed the boat? Sir, in the last 25 years, what changes you have seen in mental health scenario in Southeast Asia? This is a question from Dr. Shubhangi Parkar, professor and former head of the Department of Psychiatry at KEM Hospital in Mumbai.
Well,
Stigma, have we missed the boat?
There are 2 questions that have been asked. One deals with a change of services and the other one with stigma. Now, the stigma, unfortunately, has every probability that it will go and increase in importance as time goes by. I think that I can explain why I think that that will be the reason. But I think at the same time, there are also positive developments. And I think understanding certain things which we now understand, which we did not understand before. On the positive side, we now see a number of national programs against stigma, which have grown in a variety of countries, from New Zealand and Argentina to Denmark to various other European countries, China. There is a number of places where people have understood that stigma is the most important obstacle to overcome in making the life of a person with a mental illness again acceptable and livable. Now, there are various things which we have understood nowadays are probably not helpful in fighting stigma. For example, we have now understood that having campaigns against stigma is not particularly useful, because making a campaign, you have a one-day campaign or a 2-year campaign or something, and after that, there is a complete letdown. Things that have grown or been opened as doors during the campaign are closed again. And the disappointment of having lost that moment of where everybody seemed to be interested is quite bad. And I think that in many places they have seen that the campaigns against stigma have left behind a negative effect rather than a positive effect. We have also learned that, in fact, providing knowledge about, for example, schizophrenia will not necessarily decrease stigma, because the provision of knowledge is a very tricky affair. We can provide people with knowledge, but when we do this, we must remember that the people who hear this knowledge will be under the influence of what is being called the phenomenon of selective memory. Normally, when you listen to something, things that are in keeping, in harmony with what you believe are better remembered than things that are not in harmony with what you believe. So if you come to people in a poor community and you tell them, look, among 100 people with schizophrenia, 5 will commit a murder, while in the normal population, 10 out of 100 will commit a murder. People who have a prejudice about schizophrenia will forget the 10 and will only remember the 5, and will quote, the doctor had said that 5 people out of 100 with schizophrenia will commit murder. So that we have to change the prejudice before we provide knowledge. Knowledge as such is just to be provided at the point where the person is receptive to listen and to learn more about what should be done. Equally so, we have learned about stigma programs that they must be built differently from what they've been done in some countries. They have to be built specifically directed at the problems which the community, the patients and their families feel are important for them, because this differs from one place to another. I remember that we have done a program, for example, in Canada, and we've done the usual newspapers and radio and talks and etc. All of this was done. It was all right, but it didn't work very well. So we went back to the people who had schizophrenia and to their family and says, what disturbs you most in your life? And they said, what really disturbs us is that when we get to the general hospital, we are treated like dirt. They let us wait long. They don't listen to us. They don't believe us. They send us back to psychiatrists. They are treating us badly, although we have a demonstrably physical illness. So we stopped the radio campaign and all the other campaigns, and we went back to the people who were in the general hospital, and we said to them, look, you know, people who have mental disorders complain very bitterly about the way in which they're treated. And these people said, oh, that's very interesting. We didn't know this, etc. Anyway, they did. Many of them became aware of their own behavior and changed it. And at that point, the people with schizophrenia and their families were said, for the first time, somebody has done something useful for us. What would you like us to do to help you do more about stigma? So it was really a change, but we did not start with changing the behavior of general doctors before doing anything else. But that was what the patients and their families wanted, and that's what we did, and it was a much better thing to do. So that's another message that has come to our mind about fighting the stigma. Another point perhaps that has also been important is that it was remembering that the psychiatric services are also contributing to the stigma in various ways. If the hospital care is poor, and if people see that it's poor, they will in fact get an even worse opinion about the patients who are in that hospital. There's a number of things like this which we have learned over the years. And I think that we have to continue fighting against stigma in a very active way. Now, the main problem is that we have not only provided knowledge as being the answer to stigma, but we've also give the same message to everybody. But that's not the right way to fight stigma either. If you want to think about diminishing stigma, you must ask the policeman to find out what is the way in which he sees the mentally ill people, and in what way can we change the behavior of the policeman, because that is different from what it is to change the behavior of people in the street or of judges or some other people. So that the stigma programs have now been very sharply defined, going to the groups that may be expressing stigma or acting on behalf on that way. So there's a number of novelties in the fighting against stigma, but to my regret, I'm saying many countries are not yet willing to take an active stance about this, and that costs a lot of money and also makes life of people with mental illness miserable.
Let me come in on that note, Dr. Sartorius. Dr. Mohan Isaac, may I?
Yeah,
Yes.
please.
So Dr. Sartorius mentioned stigma and addressing it, and also mentioned other medical professionals. So Dr. Kalai Selvi has a question on how the prejudice that other medical professionals have against psychiatry can be addressed, that even psychiatrists are reluctant to acknowledge that they need help and are hesitant in consulting or getting help from their colleagues. So there are two questions here. One is, how do you overcome the stigma that about psychiatry and patients with psychiatry that other professionals have? And how do you make sure that when medical professionals have psychiatric problems, that they actually get care?
Well, one important point that I'd like to make in advance is that most of the stigma is in fact created in very early childhood. People become or take attitudes which are stigmatizing while they are learning about the world. It is the stage of concept formation, which is in the early age, 4, 6, 5, 4, 5, 6, 7, 8 years, when the children are organizing the world for themselves. That stigma is also created. It's at that age that they understand that there are various animals, big and small, brown and black and white, and some are dangerous and some are not. But what makes them unique, if they bark, they are dogs. And so they've created the concept of the dog, which is linked to bark. Now, in the same way, they make similar reductions, conceptualization about other things that surround them. So they will learn that people who behave in this and the other way are dangerous. And it's the danger which is the hook, like barking for dogs, danger for mentally ill people. That is what stays with them. It's very difficult to remove it later. So our first effort would really have to be to start thinking about reducing the negative attitudes of children in early schooling and at home in the parenting time against people who are different, against things that are not perfect as they should be. So that's, I think, that one of the important points about stigma in general. Now, when we get to the medical doctors and the way in which the medical doctors could be less stigmatized, I would say, number one, one should insist on problem-based learning and education much more than we are doing now. There should be no sentence, no case shown only because he has a, I don't know, particular broken leg, and there is only the surgeon or the orthopedist who is operating there. No, the training about a medical student must be to see what are the various components of that broken leg person. He is afraid, he has great pain, he doesn't know whether he has money, whether to pay, etc. There's a variety of aspects of the broken leg which has to be learned early in schooling together. So my first answer would be, let us ensure that the training of medical students is done to a large extent jointly by specialists, various specialists, including psychiatrists. Number two, we are living surrounded by other people who deal with mental illness, for example, nurses, for example, social workers, lawyers. It would be important that certain amount of training about psychiatry is given to all of these professions at the same time in the same room. So the doctors respect the nurses a little bit more, nurses respect the doctors a little bit more, and they become a team because they have grown together, not because they sit in the same department. And I think those two lines of problem-based learning on one hand, and to extent possible, joint education of various professions that deal with mental illness and with healthcare in general, are two streams that will be very important. A third stream that I think has been neglected to a large degree has been the stream of selecting people, A, for medicine and B, for psychiatry. It is, some people are not made for medicine, and they should be advised early on that there may be other things that they can do in life. And equally so, once they finish, it would be very important for people who are entering psychiatry that they be selected because they are having the personality and the style and the interest and the manner in which they live, which is suitable for psychiatry. Many of them are unhappy while doing psychiatry because they've entered into this discipline wrongly. It's not something they like. It's something which they do because they are afraid they've lost 5 years of training if they don't continue. And so they are miserable, and their patients are miserable, and they're miserable psychiatrists. And I think that is an important thing to understand, that early on are entering. But I would go one step further. The students of which I've recently taught, they decided they would give a gift to everybody who has attended the course. And so they asked me, give us a sentence which you can write on a bag, print on a bag to get her home. And so I didn't know what to say, but finally they said, we know what we're going to say. We are going to say, love psychiatry or leave it. And in many ways, this is true for a psychiatrist. Psychiatrists who do not like their work are bad for themselves, and they are bad for their patients, and they are bad for everybody else, and they are bad for society as well. So I think that these are some of the things if you get a psychiatrist who is knowledgeable and pleasant and enjoys his work, it will be much easier for him or her to make friendship with other doctors and to enter into their company and work together with them. That will be something that is completely different from what is happening now, where you get doctors in psychiatry who know about psychiatry, but have neglected to read general medical journals for many years, and who are not very happy with their work either, and who live continuously understanding that everybody is neglecting them and are miserable, and they do not really prove, they're not a joy to be with. And that is, I think, why many people will reject them. You have to be nice to be liked. And I think the psychiatrists should have to make an effort to become nicer than what they are at present. Many of them are nice, yes, but many of them, some of them are not so very nice. And you are all very nice, I must say.
Mohan sir, may I add an appendix question? Yeah,
please do.
Sir, it is a silly question. I like asking those. How much, so what are the chances that you are able to alleviate stigma 100%? Is it possible that given all the things, you are able to overcome stigma 100%? If not, then at what percent of optimal functioning will be able to alleviate it?
Well, one has to understand that stigma can be positive and negative. And that is something that we should also remember. Stigma is a prejudice about a certain phenomenon or about a certain group of people about something. It is very likely that it is impossible to completely remove the prejudice. Psychiatrists are the first one who have a prejudice as well. Not all psychiatrists are without their prejudice about stigma, about the people whom they are treating. If you ask yourself for a moment, if you had to employ a new secretary and there was a person with a mental illness history and one without, whom would you hire in this situation? You will understand that we are not necessarily free of stigma either. So that, yes, there is a certain amount of stigma, but we should, if we don't remove it, we should be aware of it. We should know that we have to think and know that we have a certain amount of negative feeling about this thing, and we should handle this in the specific instance when we are asked to make decisions. And that's something which is important. We will never remove it completely, as we do not remove other prejudices and feelings about other things, but we control them, and that is more important than removing them. Knowing, being aware of one's own prejudice makes you able to overcome it.
Thank you, sir.
I would like to add that for those early career psychiatrists, postgraduates who are interested in stigma, there are at least 4 books which Dr. Sartorius has either written or edited or co-edited. In the last 15 years, they have come. Each one is an improvement on the previous one. First, there was a book on understanding the stigma of mental illness, theory and interventions in 2008. Even before that, there was another book called Reducing Stigma of Mental Illness, a report from a global program of Open the Doors program from 20 countries. This was a WPA program. This was in 2005. Then in 2012, there was a very interesting book called Paradigms Lost, Fighting Stigma and the Lessons Learned. And much more recently, last year, Paradigms Lost and Paradigms Found. This is the second edition of the Paradigms Lost book, but with a lot of additional information. All these give a lot of details about some of the things which Dr. Sartorius has just now mentioned. Now, related to this, there was a question in the chat box. Do you find that there are differences in stigma, East and West? I mean, are there noticeable differences as far as psychiatric disorders, stigma against psychiatric disorders are concerned across the globe? This is a question which came up while we were discussing in the chat box.
Well, yes, I think that the main axis, if you wish, of stigma, this does differ among psychiatric disorders. So that probably the one that is until now the least stigmatized is the various forms of milder forms, in particular of depression, which are seen as understandable. There are so many things that weigh on, and most people have in their life been depressed for one reason or another. So having somebody in front of you who is depressed is sort of less difficult to understand and less difficult to accept. So that I would say that the stigma about depression in general is less severe than stigma about schizophrenia, which is a measure of a conviction that it will never improve and an immediate danger. And those two put together make the stigma around schizophrenia particularly important and to remove, and particularly important in the treatment and in the management of schizophrenia. Some of the other diseases vary in their stigmatization. It is interesting that, for example, the stigma of dementia has been very different in different countries. And in some countries, it has been completely removed by very interesting ways. I'll give you just an example to show how a country, not a country, but a group of people have dealt with this. There is a belief among the Wolof people, there is the majority people in Senegal, believe that people are reborn. That is, that you die and then you are reborn again. And sometimes there is a snag somewhere, so that you are reborn a little bit too early. So that in fact, that in the old body, the child is born again. And the behavior of that old body with the child born again is like a child, not necessarily continent, very often incontinent, not behaving properly, losing its way, etc., etc. Many of the things as if it was a child. So they look after that child, of that person who was reborn. And many children then die. And so this elderly person with dementia, who has been considered as a reborn into his own body, once more, are accepted and looked after with great care and great attention. And mothers in particular of children are making sure that it's given food and that it's given advice and protection and other things for people with dementia. It's an interesting way in which a nation, or rather a group, has shaped the idea of dementia and accepted the people with dementia in a very positive and friendly way.
So a related question about schizophrenia. Dr. Paresh Shah from Rajkot asks, do you think we should change the name of schizophrenia? Similarly, Dr. Gurvinder Pal Singh from Batinda asks, in future, will there be any advantage of renaming schizophrenia by any other alternate name?
This is a matter of
These are the
great
questions
debate.
about.
In fact, the nice thing about it, however, is that we have at least 4 examples of which we can look at. Number one, in Japan, the families of people with schizophrenia have been in a organization, and they, together with the psychiatric patients and with the psychiatrists, decided they would change the name of schizophrenia. For them, that was very important, because the name of schizophrenia in Japanese is translated. For you and I, it's not translated. We are still using the Greek word, which means the broken brain or the split brain. But we are not saying to a patient, you have a split brain. We are telling him you have schizophrenia, which is different. Now, in Japan, however, when you said to somebody that he has the diagnosis of schizophrenia, you would have to describe this as the broken brain. And that was very depressing and for the patients. And very many psychiatrists did not give the diagnosis to the patient at all. They could not bear the reaction which they got when they said to a person that he had a broken brain. So they decided they would change the name of schizophrenia, and that they would change the name, and they found the name which was something like, I'm roughly translating, a disorder in the coordination of thinking. Now that people who had schizophrenia, in fact, recognized that as something that is before them. And they, in fact, said, yes, yes, that is exactly what happens to me. So a disorder in the coordination of thinking was changed. All the laws of the countries have changed, and the name of this new name has been introduced. Now, what were the consequences? Well, 2 years after that, Professor Sato has done a survey to see whether there is any difference. And he found that while in the past only 2 to 5% of psychiatrists were able to say their diagnosis to the patient, after the new name was introduced, 70% of the psychiatrists were telling their patients what their diagnosis was. In general, it was also a little bit better, a better reception, and the patients themselves, many of them felt much better about their diagnosis and about their life. The Koreans looked at this, and they were interested to see whether this is really true or not, so they decided they would change the name as well. And they changed the name to an even nicer name, which was the name and thought attunement disorder. You know, like when you have a piano and you will to tune the piano, so the brain also is not attuned properly. So the attunement disorder was also quite acceptable. And in most of those countries, the new names are used in general. It seems that they have been well received and that the result was positive. A survey in China where they proposed to change the name gave 3 types of results. Some people said, yes, we want to change. Some said, I don't care. And some said, I do not want to change. In France, they did not want to change for the simple reason because their amount of disability pension which is getting to them depends a little bit on where the disease is grouped. So they didn't want to change it very much. So my answer is, it is possible to change it. It might be useful to do it, but one would have to do it properly with a appropriate anti-stigma activity at the same time, rather than to see that the new name becomes as stigmatized as the old name very quickly afterwards.
Dr. Sartorius, just to give you a little flavor of what is occurring in the chat box, lots of comments are coming, lots of some questions are coming. I am constantly monitoring that. One of the audience has offered a name for schizophrenia, and that is neurotransmitter imbalance disorder. I mean, this is just for your information. And in that connection, I must also tell you that one of the participants has paid you a compliment, saying that your accent is most India-friendly. This is just to give you a flavor of what is occurring in the chat box. It is constantly interacting. People are constantly sending various kind of comments. Now, to move on, there are questions about what is your current opinion about the etiology of schizophrenia. Do you think schizophrenia is curable at all? If so, what proportion of schizophrenia is curable? So we are moving from stigma to little more other aspects of schizophrenia.
Well, I mean, until now, nobody's got the Nobel Prize for discovering the real pathogenesis of schizophrenia. We know certain things that are important. We know that, for example, difficult childbirth influences or contributes. And my own opinion is that probably there is a variety of factors which will lead to the disorder which we call schizophrenia. Probably these various factors, some of them we know, but others we do not know. So that since this is a multifactorial proposition, it's very difficult to know what combinations of factors are likely to make the disease break out. I would think that there is a combination of physical damage, mental damage, and structural damage, which put together lead to the disorder. There's some evidence for it. For example, childbirth trauma has been seen does increase the probability of schizophrenia. The big famine in Holland some years ago has also seen 25 years ago an upsurge of schizophrenia. So it is likely that an pregnancy where the mother is exposed to some particular hardship may be one of the contributing factors that will create the disease in the final analysis. So there is I think one has to admit that it's a multifactorial disease in which probably the epigenetics plays a particularly important role, that the genetic basis for schizophrenia can be activated by a variety of factors of experience, of external circumstances, and of stresses that a person might have.
Okay. Any comment on the curability of schizophrenia? Do you think schizophrenia is curable? If so,
Well,
what? To what extent?
It's doing much better than many other diseases. The longest term follow-up studies that have been done are probably the ones in Switzerland, where people with schizophrenia who had an episode and were treated have been followed for nearly 50 years. And during that, with this follow-up, which was a complete follow-up, it turned out that approximately 1/3 of schizophrenia, people with schizophrenia have an episode which hits them, they overcome the episode, and once they are out of it, they stay well until the end of their lives. And the life is continuing without an abbreviation, so to say. There is a group that will turn into an episodic disease and will have good and bad periods depending on external factors, on food, on 100 things. And then there is a group that seems to have a bad outcome in that, and I would guess that probably it's between 20 and 30% of people who will not show a significant improvement at all. And some of the people who had previously been called simple schizophrenia, diagnosis which has now disappeared, which is characterized by a significant flattening of the affect and the disinterest and the closure, etc. This seems to still have a fairly poor prognosis and will not be getting much better over time. But I think that we should remember that the external factors that surround the outcome do influence them very much. And the schizophrenia studies that we have done in years ago have in fact demonstrated that the environment into which the person comes after his acute treatment plays an important role in the subsequent outcome of the disease.
Thank you. I just want to also report that our audience is becoming more and more creative. One person has commented that instead of neurotransmitter imbalance disorder, it should be called neural connection malfunction disorder. So that is the debate on name changes continuing in the chat box. Similarly, about stigma, somebody has commented that in India, a lot of people believe that mental disorders such as schizophrenia is a curse from God, and that contributes to delay in treatment, hiding the illness, etc. And one person has commented that in India, there is a noticeable difference in stigma between rural and urban areas. I'm just updating you on what is happening in the chat box.
Yeah,
now,
well,
the next question is, please go on.
Comment on that, what you just said. I think it's not only rural, urban, but also male, female differences in both outcome and in terms of stigma and prejudice. Sorry, yeah.
So the next question is, what, in your opinion, would be the components of an ideal schizophrenia service? And which of these components should be the priority in resource-poor settings such as in India? It is about service, moving on from etiology to what is the ideal schizophrenia service? Well,
I think that brings me to a point that is of greater and greater interest to me. And that is, we have been, in the last but 1 century, in 1840 or something, the German psychiatrists have decided that it may be better not to keep the people in hospital for the rest of their lives, but to bring them back to their house, to their family, to instruct the family about the ways of handling the problems and see whether they can be treated at home. And gradually that has grown into a movement, and it has become what has been called community psychiatry, with major emphasis on treating people at home among other people. That is very nice, except that as time goes by, many things have changed, and that we today cannot any longer speak about community care as we have spoken 20 or 50 or 100 years ago. Communities, as we have had them when these ideas were popular, have changed and disappeared. It is probably true that in rural areas in India and elsewhere, the original community still exists, but in many other rural areas, it does not. In Turkey, for example, communities are composed in many places from elderly, disabled, and children, and no able people, because all the able people have left the village and gone to town to work, and they are sending home some money, and the villages are not what they used to be. And it is true for other places as well, that the original cohesion and linkage between people who lived in the same place has completely disappeared. Well, that means that today, more than ever before, the major burden of looking after people who have a disease, mental or physical, falls on the immediate family. Yeah, that would be fine. While you have a family of 50 people, grandfather, grandmother, I don't know how many children, brothers, sisters, children, etc. But now, a large number, if not most of the families now, are a two-person family, and not only a two-person family, but a two-person family that is often several times recomposed by divorces and other things, which have one or more children, which are not necessarily looked after by them. And now to imagine that we can count on that family now, as we have done 50 years ago, is a nonsense. So that we have today start thinking, what can I do? What kind of measures do I have to take? And the first measure is simply to say it, is that the money needed for the treatment of a person must follow the person who is treated. In other words, if you have a family which is small and which has now to will accept the person who has had a mental illness, has to be looked after, somebody in that family has to stop working because they are all busy, they're doing things. So you have to think of, how do I compensate? Do I give them some money to hire somebody maybe to look after, to be at home, to look after the homework? I have to make sure that I strengthen the family before I discharge people into it. Because families being so small, they accept another person, they break down. And instead of having one person with the disease, you now have 3 or 5. And I think that that is something that is a necessary reform of our system. We have to think now, if when we are discharging a patient, what is the strengths of the family or the group to which he is discharged, number one. Number two, what would have to be added, if anything, to that particular family in order to be able to survive? What kind of strengths do we have to offer the carer? Because they are carrying the burden. Psychiatrists see patients 5 minutes in months, maybe. But these people see them 24 hours a day. And they have to be given support in a different way, not just by words, by cash, by education, by extra room, etc. If you don't do it, we are dishonest. We are saying the community will look after them. They will not. They come back, or they kill themselves, or they kill others, and create havoc. And I think that that's something that we should understand and gradually start fighting for. It is possible to strengthen the family sufficiently. Maybe there should be a nurse which comes every day to help a little bit. Maybe there should be a peer whom you pay a little bit to be with the patient. Some of them will be volunteers, but some of them will not be volunteers. But if you give a person who has had an illness a small amount of money, many of them, they're not unemployed anyway. You give them a small amount of money, he will look after somebody else who just come out of the hospital, etc. So I think we have to reshape our strategy to be in keeping and in harmony with what the reality is. And our reality today is different from what is described in the books that deal with social psychiatry, community psychiatry, and similar things.
Mohan sir, may I?
Please.
Sir, if I like to connect the two chapters of stigma and treatment, any illness that is eminently treatable has less stigma. So what are the better avenues of treatment? And now a hypothetical question: why should we not start using clozapine as first line drug, because it is one of the most potent things? So these are two questions combined. A good treatment leads to less stigma, and why not use medications like clozapine in first? What are the pros and cons of it?
Well, I think that it is of great importance that every country, because people are different and so are cultures, carries out a proper evaluation of medications, which is not only done to get a registration, but also done as a what we call phase 4. How does this medication work when you apply it in daily practice? In a way, like you are now having these musings, it would be important that psychiatrists somehow report their own experience in a more systematic way. They don't do it because they only can do it if they have done a survey of 100 people, but they have not done a survey. They just have experience, and they should gradually, their opinion is very important, and we should know which drugs are particularly effective and which are not, and we should organize our treatment in a manner that will respect the experience which people have gained. And I think that that's something which is an important thing. You are right. If we can treat the person well and the disease disappears, stigma is beaten, it will disappear. So it would have an effect on stigma as well if our treatment became more efficient, more efficacious, and at the same time in keeping with the experience of a number of people. And I'm here for an important fact as well, and that is that most of the drugs are registered, but once they are registered on the grounds of double-blind studies, they are not anymore reported except for chats. People chat about them, which is better, which is not better. But there is no systematic accumulation of data about the experience of practicing psychiatrists about which they have with different medication, which would be very helpful and which might also change policies about drug use.
It's a clozapine as first choice drug. Your pros and cons, your views on it.
Well, in China, they have been saying that there is no reason not to exclude one drug from others. And if a psychiatrist considers that this particular patient would benefit from drug A, or olanzapine, or another, then it should be used. And if it is not demonstrably better, then it should not be used. I think that the responsibility for treatment of a person must be based on scientific evidence, and the evidence is not only the first trial, but the experiences accumulated. I do not see that the notion that you cannot use this drug before you use some other is correct. They had it in previous times that you had to use chlorpromazine first, and then after you used it for a while, then some other drug, and then only you were allowed to use clozapine. And I think they forgot by that principle that being on a poor treatment for a long time made the disease worse over time and made the attitudes to the person who is having the disease also worse. So my personal opinion would be that I would say that by all means, let's be sure about the indications, but if necessary and if appropriate, use clozapine on the first line.
Sir, can I add one question to this?
Please.
Sir, there is a question on role of ECT. Where would you place ECT in today's world, sir? In the treatment of schizophrenia?
Sorry, where is it? I didn't quite understand.
Electroconvulsive therapy.
Electroconvulsive therapy.
Sorry?
No, the question is, what is the role of electroconvulsive therapy in treatment of schizophrenia? ECTs.
What is the role of, sorry, I don't, which treatment?
No. No, this is a question very specifically about the treatment of schizophrenia. There are, in fact, a number of questions on treatment of schizophrenia. You dealt with one such question that was about clozapine. What Amit is asking is there a role for electroconvulsive therapy? That is a shock treatment, ECT, in schizophrenia, and what is your opinion on it?
Right. Well, here again, we have to, it has been shown, I think, fairly well in the past that electroconvulsive treatment, when it was given like it was given in the past to anybody who wasn't behaving well. When I was a young doctor, it was a manner in which patients were punished if they didn't eat enough. They were just put there and given a shock until they ate. And so, I mean, this was terrible. And the reaction of the patients against electroconvulsive treatment was absolutely justified. But then as time went by, it did discover that certain types of illnesses and a certain type of things can in fact be significantly helped by the application of electroconvulsive therapy with anesthesia to prevent the various side effects that could have happened. For example, catatonic stupor was one of the conditions which was considered as being particularly suitable for this kind of a treatment. And I think that there are conditions within psychiatry where electroconvulsive treatment done in a proper way is still justifiable and should be used. But we must be careful about the image which we are projecting to the world by doing it at what time. So in some places, people have changed the name. They don't call it electroconvulsive anymore. They now call it brain stimulating. And then other people have changed the name as well. I am not for changing the name as much. I think that we should really behave strictly in keeping with what is demonstrated and proven. We know that certain types of disorder do react well to electroconvulsive treatment, and others we have no evidence, we just believe it might. And it's wrong to try electroconvulsive treatment just because we have it. I think we should be clear about the indications which we allow, and these indications should be demonstrated and should be recorded. So the answer is yes, but.
Dr. Sartorius, there are a couple of questions about the diagnosis and classification of schizophrenia. I'll just mention some of them. With the removal of first-rank symptoms in the diagnostic criteria in ICD-11, how does it affect our approach at diagnosis towards schizophrenia? And that person goes on to ask, with simplification of the diagnostic criteria, have we progressed or have we regressed and gone back to where we were many years ago? So there's another question. They ask about the pros and cons of ICD and DSM as far as classification of schizophrenia is concerned. And a connected question which came in the chat box about cause and outcome. Do you think there should be another study now on the lines of the international pilot study of schizophrenia, because the world has changed so much and we do not know so much about the cause and outcome? No. I've grouped them because there are too many questions and we don't have so much time. We have already taken an hour. I know the organizers are getting a little impatient. Lots of questions, lots of them coming in the chat box. To you, Dr. Sartorius.
Well, I think that the definition of schizophrenia as it was done in the middle of the last century has been as good as it can be. And since then, people have fiddled with it. For the research purposes, we have, I think, created a particularly strict diagnosis. And maybe for daily practice, this diagnosis is too strict, if you wish. But I think that the criteria that were introduced in the ICD-10 are and still are sufficiently good for clinical practice. The improvement, I must say, from my point of view, the improvement in the ICD-11 is marginal. The fact that they, for example, that simple schizophrenia is removed from the classification is, in my opinion, an error. There are people who are sort of having this form of schizophrenia, which have very bad prognosis, and it can be diagnosed very, very clearly early in the beginning of the disease. But most of the people are, in fact, not paying too much attention to the great amount of detail in making the diagnosis. And they are making the diagnosis more or less on the basis of their experience. And so I would think that there has not been a significant step forward by the new classification, for the simple reason that has not been a significant step forward in our understanding of the etiology of the disease as well. So that's for the diagnosis, I think, and for the classification. was that the main question, I think?
That was yes. Then there was a connected question on course and outcome. Do you think
Yeah,
there is a
about
need
this.
for a study on the lines of the IPSS?
I think that that's an interesting question. There have been some studies which have been done using the same instrument and same selection criteria, and they have argued that the idea or that the better outcome in developing countries, which we have found, is now, it cannot be demonstrated. I would not be surprised if this is so. A country like India has made so many changes and become so much more similar to other countries that it is expected, will be expected, that these changes are also influencing the outcome of diseases. So that what was originally positive in the community or in the family might have disappeared because the families have fallen apart. So if you did the study today, you would suddenly find that the outcome is not much better in the country, which has now become very similar to the countries like Denmark were in the past. So I think that to do a study, one more study, I would predict that the differences will be lesser than they were in the past. But that we could still find similar things to our study if we went to the, shall we say, more traditional communities and more traditional societies which still exist in some places.
Yeah, Mohan sir, may I?
Yes.
There was a question. What we are defining as schizophrenia is we are just scratching the surface. The processes that are going on in the brain, they are causing change in the behavior that we are now interpreting as schizophrenia. So the question is, schizophrenia, the disease doesn't exist. It is just a symptom. There are brain processes going on. You comment on this, sir.
Well, schizophrenia is not yet a disease. It is a syndrome. And it's a syndrome because for the definition of a disease, you must have a clear-cut description of the cause, a description of the pathogenesis, of the clinical picture, of the reaction to the treatment, and the outcome. Now, for schizophrenia, we don't have a clear-cut impression about the cause. We are very doubtful about the pathogenesis. Robin Murray speaks about the dopamine disorder because he believes the dopamine is the main thing, etc. So we don't know the pathogenesis. What we do know is the clinical picture and the reaction to treatment, and for some people, the outcome. So that's not enough to speak of a disease. It's enough to speak about a syndrome that could be the consequence of a variety of causes, and we use it because we have discovered that certain predictions about the future can be made on the basis of this clinical picture, and that certain decisions about treatment can be made on the basis of this description.
There are number of questions on the pharmacological management of schizophrenia. Questions are in this nature. Why is there a lacunae for researching newer pharmacological agents for schizophrenia? Is there any drug in the horizon for treatment-resistant schizophrenia? Some people have asked about, should we do the very strict hematological monitoring for clozapine? What is your opinion on the recent antipsychotics such as lurasidone, dexproprazole, etc.? So they are all treatment and pharmacology related. And there are also some questions which are not specifically related to schizophrenia. Several people have asked about your opinion on the psychedelics and their role. Do you think they will come up and have a big place in psychiatry? Some countries are beginning to allow use of psychedelics by psychiatrists. So tell us about psychedelics use and research about psychedelics in schizophrenia, and even about psilocybin use in schizophrenia. So numerous questions, but I just put them together for your general response.
Well, I have three comments about this. Number one, I think for psychedelics, I don't think that we have the evidence which allows us to apply it in routine treatment. It at best can be used in well-controlled trials. And once we can demonstrate that it is useful to our patients, we should be able to use it as a normal part of treatment. For the moment, such evidence does not exist. It's more experiment. Number two, I think that the Indian Psychiatric Society and the group that is here collected and others should try to think about the way in which they can bring together their experience, because their experience is precious and at present it's never shared. And one should think a little bit about maybe by creating a group that uses clozapine and who could maybe have musings about what they have noticed once they used clozapine, or some other groupings. In other words, the enormous experience that you have is all remaining in your office. It's not joining other experience. And therefore, we are expecting and we are relying exclusively on trials which have been done 30 years ago. The world has changed since then, and we should not rely on them anymore. And they've been done on well-selected samples which don't exist in reality. Patients who are described in these samples are practically never to be found. They are ideal, but where are they? They don't look like what we see normally. So I think that the current technology which we are having should really allow us to do much more of bringing together fresh experience and basing our decisions on that.
Dr. Sartorius, thank you very much. We have taken about an hour. Before I hand over back to the moderators, and who will then perhaps take up a couple of more questions from the floor, I just want to say 2 or 3 more comments just to give you a flavor of what has been occurring in the chat box as you are talking. People were thinking, people were creative. One person has said that in our part of the country, this is talking about stigma. People think that psychiatrists are already mad. If they are not already mad, they will soon become mad, continuing practice. This is just a comment. Last comment that I would like to just state here, you may or may not wish to respond. One person has said, sir, how are you keeping so fit during 90 years of age? So you may choose to answer or not.
That's the commonest question they all ask.
With that, I hand over back.
Well,
Yes.
I mean, I think that I must be grateful to God for giving me good genes. I think I should also be grateful that I have a life partner with whom I share my life, and which was extremely important. And I think also I have been over years trying to like what I'm doing. And the fact that I'm working in areas that I think are important and that are speaking to me might have also had a contribution. So that is that answer to that question. But I think that it's open to everybody, and there are no secrets about it. I think some of the things we can change, some of the things we are just given and cannot change or do anything about it.
Yes.
Yeah. So there are a few questions on the negative symptoms. So your take on this, how to better manage them, because these are one of the most difficult things, negative symptoms in schizophrenia.
Yes, they require particular attention. There have been now a number of behavioral techniques which have tried to reawaken affectivity and reawaken the affect. And it's undoubtedly the most troublesome and the most difficult part of the entire psychiatry is to deal with negative symptoms of schizophrenia. That is something where we have not yet found an appropriate answer. And I think it's very likely that negative symptoms might improve a little over a longer time of continuous gentle care, that they in fact reopen again I must say that the other aspect which is important, many of the negative symptoms are also linked to the frequency of negative comments about the patients. And Dr. Julian Leff has done a comparison of the frequency of negative comments and negative influences between India and the United Kingdom and Denmark, and found that in India there were fewer than in those 2 other countries, but they were also present here. And one of the things that one can really actively do is to think about ways in which the amount of negative comments and the acceptance of the patient can be improved, because that seems to be allowing a reawakening of the affectivity in patients and a more wholesome outcome.
Thank you, sir. Amrit.
Alim, we can take few questions from the house because sir has
Sure.
already. So a lot of senior people, anybody wants to ask questions, we can take a couple of questions before we wind
I
up.
think Ranjan is there. Ranjan, would you like to ask a question?
Yeah, thank you, Dr. Alim. Thank you, Dr. Amrit and Tufan Pati sir and Professor Mohan Isaac for bringing this wonderful session in this Thursday musing. So I have got the opportunity to interact personally with Professor Dr. Norman Sartorius in the WP Regional Congress, Kolkata, as well as here in AP annual meeting. I am right now, I am talking at the San Francisco airport. I'm just waiting for the board the flight. So my question to Professor Sartorius is that whether the perceived stigma followed by self-stigma or self-stigma followed by perceived stigma, or both are equally damaging.
Well, and there are three types of stigma.
Yes.
And they are not equally easy to access. There is first what is called the social stigma. That is, all people think that there is the mentally ill people are, etc. Then there is the second one, which is the what is called the structural stigma. That is the discrimination that is incorporated into rules and laws about mentally ill people. It's a consequence of the stigma that has found its place in legislation. Then there is what is called the courtesy stigma. This is the stigma which is spread to people who surround the mentally ill person, his wife or his husband or a child or a parent. And then there is finally the self-stigma. And self-stigma is that the person who has been disappointed so many times, rejected by so many instances, thinks that he is nobody and nothing. Now, for psychiatrists, one of the areas in which they can really make a difference is self-stigma. They can really, since they are in a privileged position with the patient, they can contribute to the reduction of the self-stigma, which people with mental illness have, and which very often is the most important, decisive part of the stigma, because they are not daring anymore to try. They don't go to look for a job because they know they will be rejected, etc. So that I think that that's where the psychiatrist can really, or not only psychiatrists, but other staff, as well as family and others, can really make a difference in which they could reduce the self-stigma and start to return self-respect to the person who has experienced the illness. It's a terribly important factor, which is very often neglected. And we are worried about newspapers, but the patient who's just been in front of us, we have not told him that we like the fact that he has blue eyes and that he is a wonderful painter or wonderful singer, although he can't find a job, and a number of other things that we could say to a person who has a confidence into what we are telling him, and therefore we can be very influential.
Sir, Lakshmi Madam is there. Madam, you want to contribute something? You want to ask something?
Thank you. It was wonderful, Dr. Sartorius, as usual. I just wanted to ask your opinion. World over, we find that suicide among schizophrenics have come down. And large part of it, they say, is due to the introduction of clozapine. So there is now talk about introducing a small amount of clozapine in people who have been diagnosed with schizophrenia or has made a suicide attempt or have a family history of suicide. What is your opinion on that?
Well, I just have an opinion. I have no data. I cannot speak from experience, and I cannot speak from the data that I have seen. The variation in the frequency of suicide, as you well know better than anybody, depend on very many factors, and on the attitude of the society, on the management of the patient's family, on the variety of other factors that play a role. It is possible that we can influence the tendency of suicide by changes in the medication, but I think that the suicide tendency to suicide depends on the totality of the factors that surround the patient, not on the medication only, and that there are many places where we can intervene, and that is the right way to go about it, rather than just change a prescription.
Thank you.
Thank you, madam.
Sir, why hasn't there been any blockbuster drug in recent times? Have we approached the saturation point? We are not getting to give. We are not going to have any major blockbuster medications now.
Well, I don't know. The answer is we have recently had not recently, maybe a couple of years ago, we have brought together at the time the heads of the major drug companies and said, all right, now what is happening here? Most of you have stopped doing research on medications for mental disorders. And they talked nonsense of different types. But what really came out is that some of the other drugs for other diseases are much more profitable. The drugs for mental disorders are not as profitable. Although there are many people with mental illness, they cannot really afford very expensive drugs. And therefore they have cheap drugs. And this brings money, all right. But the cheap drugs, so to say, which are now on the market, are unlikely to result in a major profit now. So that you get a new drug now, which has, I think, a single cure, that is a treatment for a particular form of cancer, has been the cost of $250,000 for one patient, one treatment. Now compare this with the price of chlorpromazine, and maybe the answer for their withdrawing from research into new psychotropic medications is related to the fact that their assessment of the market is that it is more likely to make money in cancer and in cardiovascular illness, but particularly cancer, than it is in the instance of mental disorder.
Yeah, Dr. Majid, sure.
Yeah. Thank you very much, sir, for a very, very lucid presentation as usual. I would like to have your comment on, see, the pathways that we have here, the referrals from different stakeholders, I would say. In India, we have referrals of these psychiatric patients from faith healers. And most of the times we encourage them and we at times educate them about what is psychiatry and what is actually possession syndrome and what is actually the other syndromes that they refer the patients to us. But at the same time, what we have seen, many of the patients, particularly with neurotic disorders, depression or anxiety, or even schizophrenia, go to the medical professionals other than psychiatrists. And I think as compared to the faith healers, I feel the doctors, particularly non-psychiatrists, actually stigmatize psychiatry more than anybody else. So what's your take on that? Is it true about that place also, or it is happening here only?
Well, I think that psychiatrists are, to my great regret, very often don't want to be doctors any longer. They are psychiatrists and they do not deal with the body of the person. I do not see many psychiatrists who ask the patient to undress, to listen to his heart when they first see him. They talk about brain. They don't talk about anything else. The general practitioner or other doctors, particularly general practitioners, they listen a little bit more. And they listen and they do look after the body as well as about the mind. And I think that they are therefore somehow seen more as being doctors. And now a doctor, as you well know, for many years has been seen as a person who knows everything. He's been a teacher. The word doctor comes from the word docere, the Latin word for teaching, because they've been teaching people how to live. And they do this on the basis of a relationship with confidence with their patient. And the patient comes to them and tells them all that there is wrong and so forth. Now, the relationship with psychiatrists has become very narrow. The psychiatrists in most countries of the world refuse to prescribe antibiotics if they see that the person also has a condition that requires antibiotic treatment. They say, go and see the general practitioner. Why? I mean, we are taking away from our responsibility and from our authority. We have been trained in psychiatry and in medicine, and we should be doing both. Now, so that I think that it is probable that people who have a disease which is on the border between physical feelings and mental disorder like depression, anxiety, etc., they'll go to the general practitioner because he's much more of a doctor, and doctors know what to do about disease. Psychiatrist only knows what to do with psychiatric crazy people. I'm not crazy, I'm just depressed, so I go to the GP.
Thank you, sir. Thank you. Abrit, any questions from your side?
I think most of the questions have been taken and Sir has been speaking non-stop.
I think we have few more minutes. Sir, your views on haloperidol, how does it hold steadfast right now? Haloperidol.
I'm out of clinical practice for a long time, so that I cannot really tell you about the effects of medications. I don't know about them anymore. I know what happened. I know that when haloperidol came into the market, it was considered a miracle drug. It was a fantastic discovery, etc. As years went by, it became an ordinary drug, and then it became an even less ordinary drug. So one of the sides because of its side effects, etc. So I don't really know of any major new studies that have been speaking about haloperidol or any of the other medications that are still greatly in use in many countries and are being standard in use. So that it would be helpful, as I said earlier, to bring together the experience which people have and see what we can say about the use of these drugs, about their effect, about their indications at present.
Sir, in your long experience, has the life of persons with schizophrenia actually improved with added treatment and many drugs, milder side effect drugs coming on, newer researches? Has the life of a person with schizophrenia actually improved over time?
Well, it depends really where we're starting. People who were in the chronic mental hospital didn't have a very nice life. So that the fact that the style of treatment has changed has undoubtedly played an important role. The fact that some medications came on the market. I would say that by and large, as time went by, the people who have schizophrenia today, by and large, have a better fate, a better life than they had before. But there have been no studies about the life experience of people in the 15th century or 16th century or in earlier times. What we know is that people with mental illness were treated terribly in many of the mental institutions and in other places for many years, and that has improved in that respect. I think that we have learned how to help people, but at the same time, while we have learned this, the world has changed as well and exposed people to extra stresses and strains. So it's a very difficult question to know this without having good evidence from the past and good evidence of today.
Sir, is rational polypharmacy better than monotherapy?
There are people who swear by both. And I think that it is probably the word polypharmacy has to be defined as well. I know of patients who have 10 or 12 medications which they are receiving. I think that that's nonsense. And it cannot be, the differences between the medications are not sufficiently important to justify their simultaneous giving. They are similar to one another to a large degree, so that I think that we are having 10 drugs at the same time is satisfying the fantasy of the psychiatrist more than the needs of the patient.
So can we have algorithms for psychopharmacology used in psychosis?
Well, probably, yes. I mean, it's all the knowledge that we have about psychiatric treatment, which is gradually accumulated. And of course, you can call it any name, but we have more or less rules that are generally accepted and which can be quoted and can be found. When you say algorithm, you may think also computer medicine, so that you stick your hand into this and something examines your hand and tells you this is schizophrenia, and then comes a message on the screen, take drug 4 and drug 5 and drug 6. That I hope will never come because still think that the presence of a doctor and the examination of the patient, listening to the patient is of tremendous importance. But it's the modern times, no, everything is done automatically, no?
Sir, are our drugs anti-inflammatory, anti-neoplastic, and if so, in how much measure?
I don't know. I can't, you would have to look up the literature. I don't know.
Amrit,
Yeah, I think sir has answered every question we had to answer. So we are putting him in
Can I just add on
Sir.
just last couple of points?
Sir.
Two comments to what Aleem asked to Dr. Sartorius. You asked, is rational polypharmacy all right? But looking at prescriptions, I can, from my experience, say from India as well as Australia, there is a lot of polypharmacy. Unfortunately, it is irrational polypharmacy. Rational polypharmacy is okay, but a lot of it, you take any random prescription given by a psychiatrist in Australia or India, it is irrational polypharmacy. That's the first point. The other point I would like to make, you asked, is the life of a person with schizophrenia better? Just last week, I was in Perth in a similar meeting, which was Dr. Sartorius also participated. It is a group called Meeting for Minds. Largely people, carers, people with the lived experience of psychosis, etc. And one of the founding members of that is a person by name Keith Wilson. He's a former Minister of Health of Western Australia, but more importantly, his son suffers from schizophrenia. He is about 85 years, closer to 90 years. He attended the meeting on a wheelchair. He said in his concluding comments of the meeting that I'm now a much more comfortable man. I can die happily. The life of my son has become substantially better. I mean, it is in a way answer to Aleem's question. I would think that this is so even in India, as many people responded in the chat box. And my last comment is, I have introduced Dr. Sartorius to numerous audience. I usually quote, you know, what the Lancet has said. He's a living legend of psychiatry, etc. But from today's discussion, going through the chat box, I have picked up one more. There was a comment wherein one person has written, it is a great pleasure to listen to the living God of psychiatry. So Dr. Sartorius, you have one more adjective, or living God of psychiatry. This is by an Indian participant of your today's discussion. Back to the moderators. One more thing. Pratima has come back. I told her, don't hide. Please put on your video and make some concluding comments. I don't know whether she's, she sent me a message, personal message. Oh, she has put on. Yes. She disappeared for some time, but she is back now.
Yes. So I was listening to most of the discussion, and as somebody has already said, yes, I think, sir, you kind of trumped me to it, and not just the living legend, but the living God. But I think what this whole conversation in the last, few couple of hours tells us is really the expanse of knowledge and wisdom that Dr. Sartorius is able to give us. Apart from the introduction in terms of his achievement, I think one of the biggest, things that are evident is really his passion to teach, his willingness to take on questions, which may not necessarily, I mean, as questions were asked about polypharmacy and, things like that, which may not be really something that he's doing, all the time actively, like many of us in the audience are. But the fact that he keeps abreast of all that knowledge. I also saw a comment in the chat box about logical treatment. And I don't think the question was about logical treatment. I think anybody would agree that treatment must be logical. It was about not reducing treatment to a completely algorithmic, compassionless kind of enterprise. And I think Dr. Sartorius is a living example to tell us how important it is to engage with patients, to communicate, to address stigma, and to really make sure that it's just more than prescribing medication and to really engage the community. The second comment that somebody made is really, and I hope that Dr. Sartorius will actually summarize what he said, because he said that in many ways in terms of a message to the medical community. I'm sure there'll be lots of messages, but Dr. Sartorius, if there is one principal message that you'd like to give the medical community, you already mentioned about psychiatrists, not really engaging adequately with other doctors, about demystifying the subject, of making it more interesting. But what is your message to the larger medical community? Over to you, Dr. Sartorius.
When you see the larger medical community, this is all the doctors in the world. But I think that for psychiatrists, it's important to remember that they should be the noblest of doctors, that they should live according to the ideals of what a doctor should be. A person who has empathy for people who are in misery and in distress, who has the knowledge which he uses wisely, and being proud of what a psychiatrist is important, because it will also help to increase the respect which people have for the psychiatrist, and by extension also for the work that he or she does. I think that that's something that we should remember, that being a good doctor is of such tremendous importance. Thinking about empathy, or relationship with other people, with people who surround us, people who are working with us. I think it's various things that we should show if we want our discipline to flourish and our patients to do well.
I remember you mentioned ethos, pathos, and logos in talking, but it's also in living. I think that these are very, very important. The way we communicate to our patients, how passionate we feel, and how ethical we are. On that note, I'm going to hand it back to the moderators.
Thank you so much, ma'am. Thank you, sir. Tufan sir, over to you.
Thank you, sir. And first of all, I will compliment Dr. Mohan Isaac, with whom I had the first discussion during ANSEPS at Bhubaneswar to have Dr. Narman Sartorius in Thursday Musings. Thank you, sir. That idea came up there, and I wished that we should have him in the prestigious 150th episode, but this occasion was more appropriate. I talked to Dr. Mohan Isaac and others, and it is nice for your kind presence over here. I can feel with whatever you have told, because I feel myself more rooted to the psychiatrist community. I spend a lot of time with them because I am a village person by myself, and I feel the rhythms. But what I feel in most of the places, the main hurdle against this stigma is acceptance in the community. I started my work, if you let me 1 minute, dealing with the lunatics who were left in a terminal radio station called Puri 20-25 years ago, because their community wanted to reject them. The train reached Puri, they were taken out of the train by the government radio police, and they loitered on the street. One NGO helped to rehabilitate them, and I helped to take them. But the syndicate people in the community still continue to reject. Still today, forget about the public. Our colleagues from other disciplines ask, tell me whether this person was being treated by you when it involves a matrimonial negotiation. As such, I don't reveal. But that hunch is in the mind of the people who are more intelligent, more educated, and our community must accept. And number one, what I perceive, this stigma is not against mental disorders. It is highest against mental disorders. It is against leprosy, which is completely treatable. It is with relation to AIDS, but everybody knows it is not communicable. Still, it is there. The mental state of the community has to change. And it is interesting if you devote time and you have some improvement, some family accepts, there is a great satisfaction. I can feel every nerve of your lecture today. Thank you, sir.
Thank you so much, sir. Amrit, over to you for the thanks. Unmute, please. Unmute.
You were very specific. Thank you. That only for thanks. I'll ask all the questions you thank, sir. Sir, thank you so much. Sir, at such an age, answering questions non-stop and unprepared, the people who were asking you questions were prepared, but the person who was answering the questions was not prepared. And you answered everything so well. Thank you so much, sir, for coming, joining us. We are a small platform which has been going consistently for the last 143 weeks. And thank you for coming and enlightening us. Thank you, Pratima madam. I gave you a call and you accepted it. It's a privilege there to have the most important figure in academics in the country with us today. Mohan Isaac, sir, you have been like a shadow to us, always with us at the darkest of nights. Australia, it might be around 12:30, sir. So what's the time?
Time is 12:10.
So
10
thank you so
minutes
much.
past midnight.
It's midnight and you are still active, smiling and looking more fresh than Alim is. So thank you so much, sir. Thank you, Tufan, sir. Thank you to a lot of people, even Dr. Gautam Sah had also talked to Dr. Sartorius about this. Thank you to a lot of people around who have helped us reach this stage where we have the best in the world with us today. And that's quite an honor to the Musings team. Thank you for this wonderful session. This will be recorded and it might be kept for posterity. So thank you so much. If we can have you.
You're muted, Amit. Unmute.
If we can have you again, we'll be more than delighted. And I'll take this occasion to also invite Pratima madam to another one episode of Musings on any topic you want, madam. After you become director, I think you need to give us 1.5 hours again, if you don't mind. Thank you so much. Thank you, everybody. Good night. Have a wonderful night.
Good night.
Thank you, sir.
Thank you. Thank you so much, sir. We are teacher now. Thank you.
Thank you. Thank you very much.
Thank you, everybody.
Thank you.
Closing the meeting now, sir.
Yep.